difficult to compare health interventions with interventions measured using a benefit-cost ratio. It's only possible to compare both things together if you are willing to do something unpleasant, which is to assign a dollar value to disability-adjusted life years saved. Okay, or more generally, essentially you are assigning a dollar value to deaths or to the value of human life. Okay, in my own work, usually it's not something I prefer to do, but specifically for the Copenhagen Consensus, I was asked to do that. The Copenhagen Consensus also gave me the dollar value I was to use to make this conversion. Okay, the value they used was $1,000 per DALI, which translates to cost per, a value of a human life of about $30,000. Okay, for a poor country. By contrast, in North America, the Environmental Protection Agency in the US uses $6 million as the value of human life. Okay, and it's the Commission on Macroeconomics on Health, which involved Jeffrey Sachs, which suggested that it's reasonable to assign a value per DALI equivalent to per capita income. Okay, anyway, this is a strong assumption to make, and there are value judgments involved, but I just want to be clear at the outset that this was how it was done. Okay, so here's a summary of the results I used to make the case for the Copenhagen Consensus. In the second column, you will see benefit-cost ratios for some interventions with direct economic outcomes. So salt, iron, deworming. Okay, folic acid was not in here, but could have been. And the higher the benefit per dollar invested, the better the investment. 30 to 1 is a very high benefit-cost ratio. In the third column, you will see the cost effectiveness for interventions that affect mortality and quality of life, but not productivity directly. And here, the lower the cost per disability-adjusted life year saved, the better. Okay, so you will see here another 5 interventions that are improving quality of life or reducing mortality risk. Okay, and here you see what happens provided you assume one disability-adjusted life year saved is worth $1,000. Okay, now we can rank a whole group of nutrition interventions and show that indeed these have all very high benefit-cost ratios. Okay, at the bottom I've included treatment of severe acute malnutrition because that was included in work on scaling up nutrition, although it was not explicitly considered at the Copenhagen Consensus. Okay, so that was a summary of the work at the Copenhagen Consensus, and then that's been subsequently used. The Scaling Up Nutrition program, one step was to try and cost out the interventions similar to those the Lancet had recommended. So this work was organized by the World Bank, and it's been published as a short book, and I had various co-authors who helped with this work. What was done was to cost out the interventions, firstly for the 36 countries accounting for 90% of stunting worldwide. So these are the countries in the pink color. And you will see there are a couple of countries in the Middle East, North Africa region in this category. Large population countries where there is significant stunting. Then likewise, there are the countries in red which have small populations and therefore don't contribute much to the global burden, but nevertheless have high levels of stunting. So we costed out the interventions that you will see here on this figure, grouped into the 3 areas, behavior change, micronutrients and deworming, and then interventions that involve food. Okay, the good news is that many nutrition interventions are relatively inexpensive. Okay, obviously, in the long term, increasing people's incomes and increasing agricultural output and increasing food intake and the quality of food is what we want to happen. But that takes a long time in the course of development. In the short term, however, we can use these other strategies to improve children's and mothers' lives immediately, whilst in the long term trying to promote better diets, better quality diets, more affordable diets. And these interventions are relatively inexpensive per child or per family or per mother. Okay, and the micronutrient ones in particular are inexpensive. Okay, I've also included some information as to the kind of delivery platform that we costed out. Okay, and here's the second part of the list. Again, these interventions. Once you get to the end, you will see that treatment of severe acute malnutrition with RUTF and also prevention of chronic malnutrition using feeding, those interventions come quite expensive. Anything that involves food is much more expensive than changing behavior or improving micronutrients. In order to do the costing, we used program costs in existing countries as far as possible. WHO, through the WHO Choice program, has also developed a kind of ingredients method for doing costing that I think at times underestimates what real program costs are in the field. We also had to take account of differences in costs across different regions. The two regions which have the highest amount of malnutrition, Sub-Saharan Africa and South Asia, have relatively lower costs because wages are lower, but costs in Middle East and North Africa are higher, and they are similarly higher in Latin America. So we had to take account of this. We had to take account of the size of the population that needed to benefit from these interventions. So these are, a summary of those kinds of calculations that were made. And then with all that information, we pooled this together to achieve the costing estimates. Okay, and this is probably the most interesting slide from this section. It's the bottom line. How much money do we need to invest? So $11–12 billion per year is a large amount of money, okay? It's similar magnitude to international donor assistance for health. So it's a large amount of money. But it's not an impossibly large amount of money. If you want to compare it to, the US defense budget or something like that, this is a feasible amount of money to try to put together. And for the micronutrients, the ones that appear in the orange color, 1.5 billion per year could achieve the programs in sufficient scale for micronutrients. And 1.5 billion is not an enormous amount of money. Okay, the bad news is that spending internationally, international assistance on nutrition is low and has not risen over the last decade. On the other hand, the good news is if you can make a strong case, as was made for international health and particularly HIV/AIDS, there is capacity in the international community to direct more resources to where is needed. Okay, so the Scaling Up Nutrition Action Plan has tried to mobilize international support around the idea that nutrition interventions are important and are a high priority. And it's not just international donor funding that's important. Although they will provide a large proportion of the money, also domestic governments in the developing countries will contribute. In particular, they contribute the salaries of the frontline workers, the community nutrition workers or the primary health care workers who will be mobilized to bring the nutrition interventions to the populations. Similarly, the private sector, the households in developing countries, will contribute to improved nutrition to the degree that, for example, fortified staples are a little bit more expensive than unfortified staples. Even poor households can afford to make that investment, and they will contribute part to this $12 billion. And then lastly, households in developed countries, the private sector, can and will in some cases contribute directly to nutrition worldwide. So I have a few slides talking about innovative financing for health, and I'm going to try and suggest that similar innovative financing might be used for nutrition in the future. So we have things like patent pools, where the people who own the patents for pediatric antiretrovirals have been encouraged to donate their patents to produce concoctions of antiretrovirals appropriate for use in developing countries. You know, a patent that's not really being used in the developed world. Okay, there is UnitedAid, which has a solidarity tax on air tickets, where every time you buy an air ticket in certain countries, $1 or a couple of dollars is taken and given to HIV/AIDS efforts. We also have things like debt for health swaps, where debt is partly forgiven in exchange for the debtor country agreeing to use domestic resources for health. Okay, I don't know if you've heard of Massive Good, this organization where you can go and click on their website and directly contribute to improving the Millennium Development Goals. Okay, and it's a technique that's been used in the developed countries. When there was the disaster in Haiti, you could use your cell phone and click on your cell phone to donate $1 or $2 to Haiti relief. So here you will see some famous people encouraging you to donate money for the Millennium Development Goals. So the guy on the left is Alberto Contador, who was one of the winners of the Tour de France from Spain. And the guy on the right, maybe you will recognize, is some famous musician who is also encouraging you to donate. Okay, I have a couple of really detailed slides showing what's happening for malaria and then showing what's happening for vaccines. So some of you, I know, are from sub-Saharan Africa, and I'm sure you're aware of these new artemisinin-based combinations for malaria. These are thought to be better drugs. They're less likely to lead to drug resistance for malaria. But you can see it's a complicated mechanism that's being used. Okay, here we have money on the right-hand side flowing from international donors. It's going to, as an advanced market commitment to the manufacturers of these compounds, who are drug companies, private sector drug companies. An advanced market commitment was made such that